Good morning, everyone, and thank you so much for joining us today for our very first session of Your Questions Answered. Today, the topics are going to be the massive blood transfusion and the IV start algorithm. And we are excited to have Jen Fritzeen back, who taught this class to Virtual Trauma Core. And all of the questions presented today were asked directly from all of the attendees who saw the original lecture. Now, we are going to have a question and answer session throughout this whole thing with me asking Jen questions and more of a conversation. But if you have additional questions that come up during this time, feel free to put them in the chat. As always, in order to get CNEs for this, you need to view the entire session, complete the online evaluation and attestation of completion. There are no conflicts, and the accreditation statement is at the bottom. As a reminder, this session will be recorded, and the link will be posted later where all of the other trauma and burn lectures live. And again, that's bit.ly/trauma burn education. And with that, I'm going to turn it over to Jen, who's just going to give you like the 2-sentence summary of massive blood transfusion and the IV start algorithm, and then we'll jump right into questions.
Thanks, Cindy. Just very quickly, in a nutshell, massive blood transfusion. Massive blood transfusion was created in response to patients that are hemorrhaging, knowing that they are losing a lot of blood quickly, and we need to replace what they've lost. And because at this point, most places are not using whole blood, which is exactly what our patients are using, we are forced to look at component therapy and how to put those components, your platelets, your plasma, and your red blood cells all back together to form what would in your body work as whole blood. And so we're going to do that in a way that's quick and efficient so we can get blood in faster than patients are losing blood and to promote hemostasis. Now, that never takes the place of stopping the bleed, which is always our first goal anytime we have a patient that's bleeding. And that's kind of my nutshell massive blood transfusion, which as we talk, I probably should also say massive blood transfusion is different than giving emergency blood. We do give emergency blood or O-negative blood to patients who just need a little bit of a pick-me-up or some volume, but maybe not be hemorrhaging when they come in the code room. And it's also not equivalent to blood that you would give over 4 hours on a stable patient who just has a drop or dropping hemoglobin or hematocrit level. In a nutshell, the IV algorithm, it's not I talked during trauma core, it's not an algorithm we really need everybody to learn, and we don't look at our outcomes and watch everybody to make sure they followed that exactly. What the IV algorithm was designed to do was to recognize when we have kids who need emergency access and to give the teams an idea of how to get access and where to go for access quickly. So if we have that hemorrhaging patient, this is not the patient you're going to want to spend time trying to get a peripheral access. It may be the patient that needs either a trauma line using a Cordis catheter or an IO. It's also designed in the more stable trauma patient that if we really don't need access terribly bad, it's just needed to get some labs that we're not continually sticking somebody a million times if they're a hard stick because we want to get a line to get labs. So it's kind of designed to look at both ends of that spectrum. So with that, Cindy, I'll let you pop into questions.
Okay, so this is the first time that we have done this. So our thought was that I will read the question that was asked from the audience from Virtual Trauma Core. And then as Jen answers it, I'm going to try to summarize her notes. So bear with us if this goes slower than we think. So Jen, your first question. Are there ever side effects from receiving a large amount of blood in a short amount of time?
Yes, there's two things you need to watch for when you're giving large blood volumes, especially red blood cells. We want to watch for a drop in the calcium. So your patients can become hypocalcemic because the additive in the blood that keeps it from clotting will bind to calcium. And I always think of it, this totally dates me, but I think of Pac-Man, the old video game Pac-Man, as the additive from the blood. It kind of chews up your calcium. And so usually after you've had 2 or 3 units Probably smart to check an ionized calcium to see if there's anything that we need to do to support the patient. The other side effect that we want to look at, again, it's because of the red blood cells, is an increase in your potassium level. That increase of potassium occurs because of the breakdown of the blood that you're losing and the fact that there is some hemolysis in the blood that we're giving, causing your potassium to rise. It usually doesn't rise high enough that it's something we have to treat, but it's definitely something to keep your eye on and to not be surprised if all of a sudden you might have a patient with a potassium, maybe, 5.2 in the high fives. The other thing I want to take advantage of saying, as we talk about side effects, is there were some questions about blood transfusion reaction. Remember when you're giving
that's on another slide too.
Okay, I'll hold. Put a pin in that.
Any short little snippet about the potassium? You said a lot and I wasn't quite sure.
It shouldn't get high enough that it needs to be treated. It's due to the hemolysis of the blood, but definitely something that we just need to keep our eye on and probably not panic if our potassium is a little bit on the high side.
All right. Well, that was our first question. Let's move on to, is there a certain type of IV gauge that the massive blood transfusion protocol needs to infuse through? And is there a certain time frame other than 4 hours that an MBTP needs to infuse over?
Remember, we're giving massive blood transfusions because we have a patient that is hemorrhaging and is most likely either unstable or is in compensating hemorrhagic shock, and they're not going to be able to compensate very long. So our goal is to replace that volume. What we want to do then is 4 hours to give a unit of blood is going to be way too long. These are patients that you're going to push, you're going to give your volume as fast as you can, whether it is IV push that you're giving it, or if you give it through something like the rapid infuser. As quickly as we can get it in, the better. With that, it then comes down to IV gauge. I can use a rapid transfuser, but if I have a 24 gauge in, it's going to take 45 minutes to an hour to give that unit of blood because the IV is way too small. You always want to try to have the largest IV that you can possibly get into a patient when you're getting massive blood transfusions. For the massive blood transfuser, they recommend nothing smaller than a 20 gauge, but if you can get an 18 or a 16 in, that's great. An IO usually is a larger gauge access, and so we can give blood through an IO needle pretty quick. Down in the trauma bay, we have cordis catheters, which go into the femoral vein. And if you put even our smallest cordis catheter, I can probably get a unit of blood into a patient in about three to 5 minutes. So always remember, the bigger, the better. The other thing to keep in mind is maybe you did get that 18 gauge in. Don't use connectors that are small bore connectors because that's going to slow everything up. We want to keep it from the bag of blood to the patient as large bore as possible.
Okay. And what's the weight limit again, Jen, for the rapid transfuser? Is it they have to be over 15 kilos or is it 20?
I believe it's over 15 kilos.
Okay.
The 20 is the 20 gauge and the 15 is the weight.
Yeah. Okay. And again,
yeah,
can I push it fast, right?
Push it as fast as you want. You can get it in there. And remember that platelets cannot go on the rapid transfuser, so those you will have to push.
I just want to make sure that we get that. Okay. How often do we use the rapid infuser with the massive blood transfusion program?
We should be using it anytime you have a patient that's greater than 15 kilos and truly need and is hemorrhaging. Definitely use it if you're unstable and you're hemorrhaging, but even if you're in that compensated hemorrhagic shock, consider using that rapid infuser, because the sooner volume is what the kid needs. And so the sooner we can get that volume in, and we can get ahead of the bleeding, the better. But also remember, stop your bleed is always your first. So how often do I actually see it being used when we should use it? People are getting much better at it. 2 or 3 years ago, I would say, you know, I only saw it used once or twice a year. And that was far too infrequent. Now we're seeing it used quite a bit, at least in the code room, because I have video, I can prove it. For those of you in the OR or the ICUs, I don't really have an answer on how often you use it because I don't have any video to back me up, but the ED has gotten much, much better at using it with hemorrhagic shock.
Anything else that you want me to add to this?
To go hand in hand with the rapid infuser, Cindy, I think we'd be remiss if we didn't talk a little bit about when to push pull and the importance of heating fluid if you decide to do a push pull or if your child's too small for the rapid infuser. Remember, blood comes out of a refrigerator, plasma is thawed and platelets are cold, and we're giving a lot of volume of this, and so we're going to drop their core temp. And so the rapid infuser is going to automatically warm your fluids, but for the volume that we decide to just push in, we need to find a mode to make sure that we're warming it up, because a cold patient is going to be an acidotic patient. And it's where we're going to increase our volume, we're going to not help our acidosis at all.
You don't like cold patients.
No.
Acidotic. And that is part of the trauma triad of death, right?
Yeah, trauma triad of death. Trauma patients, from the minute they get injured, they become acidotic, coagulopathic, and cold. And the thing that we can affect the fastest and the quickest is warming a patient up. So we want to warm them up, give them volume, which will help your acidosis, and then give them yellow product, which will help your those coagulopathies.
Okay. We've exhausted blood resources in a patient and they are still not stable. Are there other measures you can take to increase volume?
Well, I always laugh when people talk about this in the light of trauma. Now, remember, not only trauma patients use a massive blood transfusion. So this will be different if you're talking cardiac patients, GI bleed. But in the world of trauma, from the minute we start giving volume, we need to be looking at where is that patient bleeding from and how do we stop that bleed? And there should be no exhausting of blood resources, because the hope is we identify that source of bleeding, and our trauma patients should be getting to the OR to stop that bleed well before we get to PAC C. Anytime we get past PAC B in the ED, that's something we're going to look at really carefully of why didn't that team mobilize to the operating room. The other thing to keep in mind, even if we're talking about this in light of something outside of trauma, there is no such thing as exhausting the resource. So we start with PAC A, which is your red cells. There's PAC B and there's PAC C. Difference between PAC B and PAC C is platelets and cryo. Platelets are in PAC B, cryos in PAC C. And if you get through A, B, and C, you just keep circling back to B and then C again, and then B again, and then C again. And so there really is no exhausting this at the end of the day.
Start back with A.
Start back with B. You only do A once.
All right. Okay, so now that we have gone through a few questions, I just wanted to make sure that we gave the audience now that's live an opportunity to ask any questions or to let us know, is this working for you? You can unmute yourself or you can put it in the chat. Oh, we got a thumbs up. That is great. Thank you, Michelle. All right. We will continue moving on. And again, feel free to utilize the chat if you have any additional questions. All right, who can place an IO? Now, I will tell you, Jen, that this question was asked in about 4 different ways.
Yeah, I saw.
Yeah.
Any physician can place an IO. And I believe that there are nursing competencies that are around the IO. I believe that the emergency department nurses who work in the code room have IO placement as part of their competencies. And so I believe that as long as those are completed, nursing can do that. Transport also, yes.
Okay. How long does the MBTP usually take to finish?
I'm going to try to answer this in the way I interpret it, because I think there's 2 ways to interpret this question. How long does it take to get through A, B, C, and D? A lot of it's going to depend on how big your access is and how quickly we're able to get blood down from the blood bank. If you're in the ICUs or the emergency department, there's a blood refrigerator in the CICU and blood refrigerator in the ED. And so you can get started on packet A right away. And pack B, that's one of our PI metrics, is to look at how long it takes to get the blood cooler down in order for you to be able to start pack B. And so we should be able to do that rather quickly. As far as how long does it take it to, the other way I interpret this is, how long should I expect once I start to finish? It's going to depend on your patient and why is your patient needing massive blood transfusion? How long does it take us to identify the source of a bleed and determine the treatment that's unique to each individual patient? So that one's a little bit difficult to determine. I have done massive blood transfusions that have taken 20 minutes. And then we get them to the OR. I've also done massive blood transfusion in which we've been going for 6 to 8 hours.
Does the OR have a blood refrigerator?
They do not.
So the only places that have blood refrigerators are the CI and the ER.
Yes.
Everybody else has to get blood from the blood bank.
Yes.
But I guess the OR is on the 2nd floor, and so is the blood bank. So that location proximity is a lot closer.
That is, and when they're scheduled surgeries, they've usually already typed and crossed and they've called for blood, and so they have blood at the ready versus patients that bleed unexpectedly.
Yeah, I feel like that that one statement that they don't have a refrigerator might cause some distress, but there's a reason why. And they also have designated people to run and go get that blood if needed, because this is a planned thing, correct?
I don't know the answer to that, Cindy, as far as does the OR have identified people. I would assume yes, that they do.
Yeah. And if the blood's already on call, at least like the blood's ready in the blood bank, so they don't have to go through all the steps that anybody else would.
And it's type and crossed also, yes.
Yeah. All right. Are there capabilities for this in transit with EMS, the ER, and every other step on the way to the PICU?
Most EMS do not carry blood at this point. I know Maryland is looking at a protocol to start carrying whole blood, but I do not believe that is live at this point. So no, en route to the hospital, crystalloid is the best your patient can get. Once the patient gets to the emergency department, we can start massive blood transfusion. And once we start it, we can take whatever we have with us. So if we've done A and we have a cooler full of B and we haven't used it, definitely take that as you transfer to the OR or transfer to the PICU. The only thing you have to remember to do is when your patient changes location and you're in the middle of massive blood transfusion, we have to let blood bank know that the patient has moved, because they're going to be allocating units to where they think the patient is and not where the actual patient is. So it's definitely important to communicate with blood bank that the patient has moved from one location to another. Now, the one thing about using the rapid infuser, it only works when plugged in. So if you are giving blood or FFP through the rapid transfuser. Remember, as you move through the hallways, you're going to have to push it until you can plug that machine back in when you get to where you're going.
The rapid, well, and the rapid transfuser or the rapid infuser, I just want to make sure I call it the same thing every time. Rapid for a reason. So chances are you're going to be done with that before you move. And has transport ever taken blood with them to go pick up a child? Okay.
Yeah, they have, and that's fine. And what they've done is they've went ahead and taken it from the ED refrigerator. Obviously, they make sure that people know they sign it out like they do in the ED. But if they don't use it, they can't put it back in the refrigerator. If you don't use it, it needs to go back to blood bank. Blood bank needs to know what time it was taken out, and they'll decide that if it can go back into use or it needs to be wasted.
That's an okay way to put that,
Yep.
Or do I need to add any caveats? Okay.
Nope. That's fine.
All right. How are transfusion reactions handled in the acute massive blood transfusion situations?
They're really not. So remember, one of your transfusion reactions is hypotension. Well, your patients are getting massive blood transfusions because they're in hemorrhagic shock. So the likelihood of hypotension is they're unrelated to blood. Another blood reaction is fever. That blood is going in way too fast for the fever to hit at anytime soon. So it's not even anything that we're watching for. Because at the end of the day, even if they spiked a fever in the midst of giving massive blood transfusion, the risk and benefit of stopping that is bad. Bad things will happen if we stop that blood. This is kind of the keep them alive mode that we're in until we can stop the bleeding.
I get a rash.
Honestly, I personally have never seen a rash through a massive blood transfusion, but again, I think we would have to probably deal with a little rash and throw a little Benadryl at them when they were a little more stable. But again, remember why we're giving this. We have an unstable patient who's hemorrhaging, and a rash probably shouldn't stop us. Note it, but don't stop it.
The patient will die without the blood.
Yeah.
A rash is I've never seen it.
Not during massive transfusion. I mean, usually when I've seen a rash, it's been on those patients that we're giving blood to, and it happens kind of after it's been infusing for, at least 30
15 minutes. And that's
Yeah.
after the blood would already be transfused for us. Yeah.
Exactly. And remember, we're giving a lot of stuff really fast. We're not going to be able to identify what is causing that transfusion reaction either.
I think that's an important note.
Mhm.
Hey, which part of the blood is most important?
There's no component that's more important than the other one. Remember, they all do different things. And you need, in order to mimic whole blood, you need to have a little bit of all of it. So you have your red blood cells. They're going to increase your H and H, which is your oxygen carrying capacity. They'll also obviously give some volume, which is needed for the acidosis and the volume loss. Your FFP is going to help you through coagulopathy. It's going to help decrease your INR, and it's also it's a great volume expander to help with the acidosis. And then your platelets are going to, as we give the red cells and the FFP, it's going to dilute out all your platelets. So if we dilute out all those platelets, we need to replace the platelets. And so your patients are able to clot. So there's not one function that is more important than the other one. We have to remember that they all have their job to do. I think back to early in my career, and I don't want to tell you what year it was because it really dates me. But I remember working in the PICU, and we would really focus on red cells. And then everybody would wonder why our kids were oozy. They're oozing out of around their IVs, they're oozing around any openings, sutures or anything. And it was because we were giving so much red cells that they became more coagulopathic because we had diluted out all the clotting factor.
You know what? I'm going to make a little table.
Okay.
And maybe, Jen, maybe we can fill this in together.
Okay.
1, 2, 3. So we have our component, job of the component, and why to replace.
Okay.
So we have
your red cells,
RBCs, then we have our FFP.
I would do FFP / cryo because remember, cryo is plasma without all the volume. So they do about the same thing.
Okay.
Okay. So oxygen carrying capacity. We want to get oxygen to those cells that are kind of dying because we're not getting any blood there.
You need to breathe.
Yep. All your cells need oxygen in order to live.
Okay.
This is going to be to increase its clotting factor. It's your fibrinogen. Your ion, we're replacing it to improve your INR. And so you won't be all oozy. And
Okay.
And job clotting. And same thing, don't want to be oozy. Finding to be able to clot.
I think that's a nice way to put that together because there's sometimes, especially if you're not somebody who gives a lot of blood products all the time, that you miss this stuff. Oh, do you think it would be helpful, Jen, to add in a column on here to say what's in the packs? We've talked a lot about ABC today, and we haven't really.
Yeah. So.
Oh, hold on. Let's see. Insert. There we go.
Okay. So red cells are in pack A, B, and C. FFP is in A, B, and C. But cryo is only in pack C. Sorry, Cindy.
P. Pack A, B. Cryo is only in. Okay.
And platelets are only in pack B.
Yeah, I think that's really helpful.
Yeah, I think so.
Especially if you are, even if you are a nurse on a unit that has never given the massive blood transfusion protocol, if a child ends up going through their whole hospital stay and then comes to the floor where it's just not used very often, if you hear MBTP, we did pack A, B, and C, you know what that patient got. We have a question. Okay.
The question is, if FFP, cryo, and platelets all do the same thing, why use both? They both do. They're both important in clotting. FFP and cryo is basically FFP without all the volume. So it's fibrinogen and improves your INR, but it doesn't increase your platelet count. And the platelets are not going to affect your INR. It's only going to affect your platelet count. Now you need your factor and your INR in order to not ooze, just like you need platelets in order to not ooze. So where they both affect coagulopathy, they do it in a different way.
And anything else that I should add?
No, why don't you put in there that where cryo, FFP, and platelets all improve coagulopathy, they do it, they're both needed because they do it in different ways. Platelets include increased platelet count, cryo, FFP, improve factor, and fibrinogen.
Anything else?
No, I don't think so. You know, it would be helpful, Cindy, just note to both of us as we decide if we're ever going to do this again. This is where it'd be nice if I could pull in the clotting cascade, but I don't have it at fingertips to be able to do that right now.
Yeah, I was thinking about that also for the IV algorithm of like have a couple things redone. But okay, so this is good. But I think this is still great. And thank you very much for asking that question. That was super helpful. Okay. There's quite a few questions about the IV algorithm, so I thought we could cover each one on this slide. So the IV algorithm, is this nurse-led or physician-led? Because sometimes IOs are delayed because of provider preference.
We have never really, we kind of put it together as a concept, not necessarily a granular guideline or protocol that you have to follow. It was more put out as a concept to help people think about and really pay attention to time. Shared mental model, that's a great way to put it. And so we've never determined, is this a nursing-led algorithm or a physician? I would say it is kind of one of those team decisions that we can kind of peer check with each other. You know, you have a patient who's coming in, you know, they're hypotensive. Hypotensive kids are almost impossible to get IV access on. And so we know we're going to want to give drugs or blood or something fast. So I now hear both from nursing and physicians independent of, do you want an IO or let's get an IO at the bedside? So I think it's more, this algorithm was more created to increase awareness versus let's put it up and follow it. So maybe algorithm was not our best title.
Well, algorithm, it is an algorithm because there's a flow.
Yeah.
But it's more of a shared mental model algorithm of like, just reminding everyone in that code room that we waste 10 minutes on getting an IV when we could do an IO in less than 15 seconds, that, you know.
And in a stable patient, that's okay. But in a patient who is unstable, who needs drugs, who needs to be intubated, who needs blood, that's when we're having problems with it.
Okay. How often do we deviate from this algorithm?
All the time, and it's okay. But now when we deviate from it, you can actually hear conversations about decision-making. And so every patient and their situation is unique, which means that their needs are unique. But people are, since we put this in front of people, it's caused them to start thinking about, you know, this kid is a GCS of 15 and is sitting up talking to me. I really don't want to put an IO in. So let's see if we can get an IV before, you know, in order to do what we have to do, versus I have an unstable patient. Why don't we have an IO at the bedside? And it's also making teams who are trying to get peripheral access that permission to say, hey, I'm not able to get this. Can we go to the IO? So definitely a great conversation starter to do the right thing for each unique patient.
Jen, I really think you brought up a good point where, and I got to figure out how to summarize it, of this also kind of takes some of the pressure off people getting an IV of like, stop, like there's definitely an urgency, but it gives them a way to say, I'm having trouble. Maybe this isn't the right thing. So how do we say that? I don't want to say it gives people an out, because people aren't looking for an out, but I guess it
gives
opens
them
the door for more open communication.
I think prior to doing some of this, those people who are trying to start IVs, they felt the pressure of, oh my God, if I can't get this, we can't treat this patient. And so I think it gives them that second option or a different option to fall back on when things are hard.
A reminder of other options.
Yeah. And for the really unstable patient, it frees the team up from having to spend time even working on the IV so we can move to the more important care.
When obtaining IO access, how long should access be obtained before getting an IV? So
okay.
It's written a little bit weird, but I think you understand.
No, I understand the question. It's a really hard question to answer because it really depends on your patient's hemodynamic status. So we could get an IO in and give some volume, and their distal pulses come back, they're warming up, they could look like they get good blood flow. And so I would say, go ahead and try a peripheral IV at that point. So maybe the best answer to that is, does your patient have peripheral pulses? Do they have distal perfusion which is so important to getting an IV? If you don't have distal perfusion, it's really hard to get an IV. So maybe that's the answer, or the rule of thumb that we go by. For other patients, we put a lot of IOs in the code room in the emergency department, and then they go up to the PICU, in which they'll transition that IO pretty quickly to central access.
But they will keep the IO in if needed. And our guidelines say 72 hours. That's been like up for debate for many times, but I just took PALS and we talked about like how many hours an IO can be in and used.
Okay, I have to be honest, I don't think I've ever seen an IO last 72 hours.
Oh, I have.
Have you? I have.
At least 48, but I think we took it out because we had a central line and a couple PIVs, but yeah, I've seen them last for a while, but it was like in a larger kid. It's in a larger kid, not in a baby. Those don't seem to last, but it's a great IV. It's the uncollapsible vein, which I think is something we have to like remember as providers, is like you're talking about like peripheral pulses, and like when you are losing volume and you're losing pressure, like all these nice hoses that we have in our body just go, and you can't put anything through a
right. But the other thing to talk about with IOs, because I think we all hear, oh my God, an IO, that sounds so painful. I don't want to do that if the patient is even remotely awake, because it sounds awful. And I don't disagree with that. I don't think I'd like an IO put in my leg anytime soon. However, when we moved to the easy IO drill compared to the old Jamshettis, I've been told, I have not let anybody put one in my leg, so I'm just going with what I've been told, is that it doesn't necessarily hurt. It's uncomfortable to put it in, but it doesn't actually hurt. When Easy IO Drill first came out, I actually met the designer, the inventor of it at NTI conference, and he was actually drilling into his own leg, showing us that it worked, and wasn't making any kind of face. And maybe he's just really a good actor, but I think it does help alleviate some of our stress when we do put that IO in a patient.
Yeah, there are being in the field and paramedicine, and even with the Jamsheedes really, placement of an IO is not painful. It's the infusion of fluid that is
At
what
first.
is killer. And a lot of times in adult medicine, I haven't seen this done in pediatric medicine, because most of the time in pediatric medicine, if we're putting an IO in, the kid's completely out anyway, so they're not going to feel it. But they'll mix some lidocaine in with the fluid to like numb that area a little bit. But anything else? Excuse me. I think
Not that I can think of, and not that I remember seeing it.
okay. Is there any situation where you would place a central line? And I think that this question is the setting would be the ER.
If I needed, if I couldn't get an IO and I don't have IVs and I have a hemorrhaging patient, I would prefer, the trauma service would prefer that you go with a Cordis catheter. There's 2 sizes of Cordis catheters stocked in each code room, so you can use them on infants and young children. The Cordis catheter is a single lumen, large bore catheter that goes into the groin. Once that patient is stabilized and brought up to the ICU or the OR, they can use that to thread in a double lumen or whatever they decide they want that's a little bit more stable. But we found, and this has been years since we've done this, we used to put central lines in the code room, and two things happen that we don't want to see. One, it seriously increased time spent in code room. So it delayed us to get to CT, it delayed us to get to the OR, it delayed us getting to the ICU. The other reason is because of contaminants. I used to work in the ER, and so I don't mind saying there's lots of cooties in the ER. And as careful as we try to be, the code room is not a very well controlled environment. And so when we're trying to prevent BSI, that's probably not the best place to put a line in.
Oh.
I have to say, Cindy, your typing is beautiful. I everything when people are watching, so you're doing great.
I didn't even think that would be a thing, and then we started. I went, "Oh God, this is gonna be a mess." I was like, "Everybody's gonna watch my typing skills. This is not good."
You're doing well.
Okay, yeah, I think I'm really glad that we talked about the Cordis catheter and what it's called. It's also called the trauma central line and the Cordis catheter. It comes in the packaging. One of the big differences, especially if you're a PICU nurse, you're used to seeing the central line kits all the time. The Cordis catheter kits have all of the writing on the front is almost like a purple. And that's like a quick way to see, like, this is a Cordis catheter, this is like a central line. Like the differences between like a regular central line you would put in a kid versus a Cordis catheter. Anything, do you know the sizes, Jen, and like what off the top of your head?
Off the top of my head, I don't.
Yeah, I don't either. I
want to say 4 and 12, but
I think it's 8 and 12. I think it's 8 and 12.
It might be.
Because 8 makes sense for smaller kids and 12 makes sense for bigger kids for like the catheter size. But I'm not sure. That is something that we can definitely follow up on with like the next iteration of this.
Yeah.
Okay. Do we still need to send everything back, the bags, the tubing, etc., with the massive blood transfusion protocol?
It depends if you use bridge or not. If you use bridge, you don't need to send anything back. If you do not use bridge, everything has to go back.
That is most of the time in the code room. That's a really good question as well. Anything else you want to say on that, Jen?
That's all I know on that.
Okay. Going backwards, hold please. Okay. What is the most common mistake made during this process?
Ooh.
I have one.
Putting a small line in and giving it too slow. I think sometimes people are afraid to give blood products too fast. I would also say another.
Oh, here, let me just make a line in.
Yeah, putting small, cold, giving cold product. What's the one you had, Cindy?
The one I had is not recognizing fast enough that we need the massive blood transfusion.
Yes. Identify
because I think that if we
hemorrhagic shock, yeah.
Yeah.
Especially because kids compensate for so long.
Yeah.
And so you'll have a kid with an okay blood pressure, but their tachycardic and their distal pulses may not be great. And that may be all you're getting.
You know, I feel like, those of us who have been in trauma for a minute, we're like, they're a little tacky. They'll be fine. They'll be fine. They'll be fine. And then you're like, oh, they're not fine. This is not okay.
Well, and that's why I always lead people to distal pulses. To me, distal pulses, if you don't have distal pulses, you got a problem. You have distal pulses, life is good.
I think that's a really good, that's like a pearl.
Mm-hmm.
If you have distal pulses, you probably don't need the massive blood transfusion program.
Agree. It's kind of the first thing I touch when a kid rolls in is what do their feet feel like?
Yeah. Are they cold? And do they have a
Yep.
pulse?
Yep.
Okay. Circumstances when the massive blood transfusion protocol would be initiated other than the trauma bay.
Well, the CICU uses massive blood transfusion protocol more than any place else in the hospital. And they're using it for a multitude of reasons with the heart patients. One of them is as kids are becoming unstable and you need to go on ECMO. We've seen the PICU. PICU has multiple reasons they've used it. One of them that I got involved in was a GI bleed. Your hemonc patients who are, in hemorrhagic shock because they're bleeding from probably, God only knows, but the hemonc patient bleeding for one of many reasons. Any place in which your patient is hemorrhaging for whatever reason that is. NICU has used massive blood transfusion a number of times in some of their, I can't even tell you what was going on with the baby, to be honest with you. I don't remember. But anytime there's hemorrhagic shock.
I hate spelling hemorrhagic, so I've been trying to avoid it, but I feel like this is what
I always do hem shock, HEM.
Oh, wait, let's see. I can't spell. There we go. Hemorrhagic. I just have to remember that. Hemorrhagic.
I know.
Like that's also like a pearl. You're in hemorrhagic shock.
And honestly,
and also stop the bleed.
There's the blood bank, the blood utilization committee that quarterly we review all massive blood transfusions protocols, activations. And it's not uncommon to find that most MBTPs maybe use Pack A and Pack B and that's it. So even if you use Pack A and you stop because you're able to find the bleed or stop the bleeding, it's okay. It's a way to get a lot of product to you and a lot of product fast if you think you're going to need it. I would say don't ever be afraid to overcall it.
I'm going to take we only have 11 minutes left. So I'm going to take a quick break and I'm putting in the evaluation for the class in the chat to make sure everybody has it. Again, make sure that when you get to your CNE certificate and you put your name and the date that you took this class in, make sure that you print or screenshot that certificate before you press submit. Otherwise you will lose it. We will try, we have 1, 2, 3, 4. We have 8 more questions. So we will see if we can get through them in 10 minutes. Oh no, we have less. Okay. When doing the massive blood transfusion, is blood usually given through a PIV? Or you're muted. Jen, you're muted.
Sorry, I coughed. I didn't want everybody to hear it.
Oh, no worries.
We actually are using IOs more than anything, but if patient comes with an IV in place and we're able to get it in quickly, we will give it through a peripheral line. So whatever access we can get quickest. And often we're going to put a second access in these patients as we start it. And you know, that actually is something to add, Cindy. If we are giving blood through one line and then we get another line, you can get blood through, or red cells through one, platelets through the other, or FFP through one and platelets through another. Don't think you have to go one at a time. If you have 3 lines, give 3 products.
I feel like that's an important pearl. Hold on, I'm going to bold that.
There was a
give
chat. There was a comment, I'll just read it. And it's actually a very good idea. Somebody said maybe we should put distal pulse check multiple times on our trauma documentation. It's one of the best things to reassess in these patients is to know your hemodynamic status, especially in the code room where the monitor is not always the most reliable thing to look at a heart rate. A distal pulse will give you a ton of information. So that's actually a really good idea. It might be something we look to include. So thank you, whoever that was.
Yeah, I think I should put that. I'm going to add that to the slide.
Mm-hmm.
Maybe add to trauma document.
That could be
3 to 5 minutes.
Yeah, with vitals. Julia, thank you.
That's great. I really like that. Okay. I think this is hemorrhagic shock.
Yes.
Can I spell it? Hemorrhagic shock.
Well, stock.
Oh, I think I did spell it right.
Did.
Yeah, I think we did answer that. Okay, well, that's good. What type of research studies are being done to show the success rate of MBT in different types of trauma?
Most of the research that we see in MBTP is adult research. It all started with the military. There is multi-center PEDS research that is being done. And so it will be out. And basically what it's doing is looking at different ways to do component therapy. But probably the latest and greatest research that's going on right now in the pediatric world with massive blood transfusion is how to convert to giving whole blood. And that study possibly could be coming to a hospital near and dear to you all.
Love that idea, because then everybody gets everything that they need all in one fell swoop.
Yep. The problem they're seeing with whole blood therapy right now is they have to make sure it's low potassium, tighter low potassium, because if you give more than a couple units, they've seen it drive potassium up a little too high. So it's one of the things that is being worked out in the PD world.
Need to make sure that what about the potassium?
That's one of the problems they're finding with whole blood transfusion is it's driving up potassiums. And so like Pittsburgh is using whole blood, they'll only use 2 to 3 units of whole blood before switching back to component therapy because of potassium levels.
Okay. Yeah, and then trying to put potassium back in a patient is a heck of a lot easier than trying to get potassium out, because none of those things are fun for anyone involved.
Yes.
How do we decide as a hospital? Oh, I think we just discussed that. I'm just going to delete.
So, but I think everybody, there is a blood, it's called blood utilization committee, and that's where all the decisions are brought as far as making hospital decisions. I will also share that Dr. Delaney, who is the chief of pathology and blood bank medicine, came to us from Seattle, and she is incredibly innovative. And she's how we got the refrigerator, and is really looking at, we now have thawed plasma available. She's looking at whole blood. And so really looking at what it is we need to do in the world of blood bank to keep us with the latest and greatest. Who is on this blood? There is multiple physicians, surgeons, anesthesiologists.
Okay, so blood bank is on it.
Critical care medicine. Matt Sharon, Matt Sharon is the chair. Anesthesia. There's representation from NICU, oncology, HEMOC.
PICU. Oh, we already got you. HEMOC, okay.
But PICU nursing too. There's probably several more people I'm leaving out, so I apologize if I.
Would the lab be involved in this, Jen?
Oh yeah, labs there, blood banks there.
Because I feel like with all the issues with like labs and everything, that would be.
Yeah, labs there.
Is transport on this?
No, they're not. I don't think so. Pathology, obviously the pathologists are on there.
That is that's quite a group.
Yeah,
sounds like a party.
Some different surgeons on there. I know orthopedics is represented. Yeah, it's a well represented meeting.
Yeah, I think that's great. All right, we have 3 minutes, so let's do one question and we'll pick it. Okay. Either how often do we do blood? Well, we can answer this quickly. We shouldn't.
I have not seen us do massive transfusion on the floors at this point. All blood that I'm aware of occurring in the acute care is the over 4 hours stable.
Yeah, and I feel like if a patient needs a massive blood transfusion, that they should be in an ICU environment.
Yeah, we're heading to the OR.
Yeah, I'm not going to say that. We have not seen this happen, nor should we.
All right.
Great, we have a comment in the chat really quick. Oh, hold on, I'll send out the link again.
Okay.
Right. Oh, we already answered that question, which is great. And
I actually see nurses putting a lot of them in. They're putting most of them in that I'm seeing now.
Yeah. And then we talked about this too with when we made that chart. So we'll just go back to the chart to review.
Yep. This is at the beginning.
Here we go. So again, like why would we give because we always start with pack A. So I guess a good question to follow up with that for the last minute here is, why are emergency cells, again, that is different than pack A or the massive blood transfusion, because why would we the question was, why do we give RBCs versus cryo versus FFP versus platelets?
Well, we're going to start with RBCs because of the oxygen carrying capacity. Make sure that we are optimizing the amount of oxygen that we can get to the tissues at all times. So not only will red cells increase our volume, so it increases our circulating volume, but it increases oxygen carrying capacity. So that's why we start there. And then very quickly, then we'll start introducing that yellow product to work on the coagulopathy. But I think we can all agree if we don't have oxygen, nothing else matters. So that's definitely the place to start.
Yeah. Well, and thank you guys for joining us today. And you guys were the very first group for this new thing that we're trying with doing like a question and answer based off of your questions from Trauma Core. A couple ones that we have coming up. We're going to do one with Dr. Artis that will not be recorded because of the sensitive nature of the topic, but we are also doing one with Dr. Maceros, and that will be recorded. So if you can join, and if you can't, just watch it later, and it will be on our YouTube channel, which is the bit.ly/trauma burn education. Thank you guys so much. I'm going to go ahead and stop recording.
You guys have time for one more question?